Hospital, Bangalore. So after all the exciting and brainstorming sessions, now we come to the systemic sclerosis, which is a multifaceted chronic inflammatory conditions, which poses a lot of real-life challenges in terms of diagnosis, complications, pregnancy, etc. So the theme of this discussion is real-world scenario in scleroderma. To start this session, I would like to call chairpersons Dr. Yogesh Preet Singh, who is my mentor from Himalayan Institute of Medical Sciences, Dehradun, and Dr. Shirisha Komireddy from Nellore. So there are three topics for discussion: practice dilemma, ordering and interpreting autoantibody in scleroderma by Dr. Sonal Mehra, followed by the practice tips by Dr. Yogesh Preet Singh. The second will be pregnancy outcome in systemic sclerosis, real world data by Dr. Kaushik Bhojani. And the third will be the update on systemic sclerosis, CTD associated PAH, predictors of survival by Dr. Ramya J.
Very good evening to all of you. So today my topic is about practice dilemmas in ordering and interpreting autoantibodies in systemic sclerosis. As you all know that scleroderma is a heterogeneous disease with a very high mortality. It is characterized by pathological vasculopathy, immune dysregulation and fibrosis that eventually leads to end organ damage. Now the ACR-ULR 2013 criteria included the anti-centromeric, anti-topoisomerase, that is the anti-SCL70, and the anti-RNA polymerase 3 antibodies, scoring it to 0.3 in the eventual diagnosis of systemic sclerosis. And now we diagnose patients with very early systemic sclerosis, which is the very early diagnosis of systemic sclerosis, which includes patients with Raynaud's, puffy digits, ANA positivity, scleroderma specific antibodies, and nail fold capillaroscopy findings of nail fold dropouts. As we all know that patients could either present at a limited disease subset, a diffuse subset, those patients without skin sclerosis with end organ involvement, or patients who have scleroderma with rheumatoid or myositis overlap. These patients eventually develop digital vasculopathy, gangrene, GI manifestations like GAVE, interstitial lung disease, pulmonary artery hypertension, cardiac fibrosis, SRC, that is the scleroderma renal crisis. Progressive arthritis patients also develop calcinosis and digital contractures and acro-osteolysis. Now coming on to scleroderma specific antibodies are against the topoisomerase 1, the anticentromeric, the RNA polymerase 3, the ribonucleoproteins that includes the U11, U12, U1 RNP as well as the U3 RNP, and the nucleolar antigens that includes the DHTO, the NOR90, the KU, and the newer antibodies like the RUV-BL1 and 2 along with the PMSCL. Now when we look at the ANA patterns on the immunofluorescence, we see those patients with topoisomerase could present either with a speckled pattern like shown in image 1 along with, or they could present as a diffuse pattern which is not shown here. The overlapping patients with myositis overlap could present with a nucleolar picture or a discrete speckled pattern which is seen in a centromeric, more commonly seen with patients with limited disease. So commonly when we see ANA patterns, we see patients either having anti-centromeric producing a discrete speckled, topoisomerase 1 showing a homogeneous or a nucleolar or a speckled, and the anti-RNA polymerase showing a nucleolar or a speckled pattern. Now also the anti-ELF2B factors, these antibodies could have ANA negativity and they could produce with cytoplasmic fluorescence. So as we see that the prevalence of these antibodies are actually very low, like for patients with diffuse disease actually have just 10 to 42% of antibodies, while patients with limited disease would have centromeric in 20 to 40%. So we just cannot rely on these antibodies, so we need clinical manifestations along with autoantibody to conclude that they actually are patients who are systemic sclerosis patients. Now, another 5 to 10% of these antibodies are the very rare ones like the THTO, U11, U12, PMSCL, which is seen in only 1 to 5%. So, the significance of these antibodies is, if we look at patients could have either limited or diffuse. Now, these antibodies are guiding us to what clinical spectrum patients could have. Now, beginning with centromeric. Centromeric is patients who have limited disease. They usually have Raynaud's, digital ulcers. They have GI involvement, like the CREST syndrome is a part of the limited disease spectrum. And later, they might develop pulmonary artery hypertension. And they do not really have malignancy or interstitial lung disease. However, patients who have a lot of GI manifestations could have GI malignancy. The other antibodies with limited are the U11, U12 who have ILD, GI and cancer involvement could be there. The THTO ones, which is a small subset, could have ILD and PAH, and the anti-NOR90 could have ILD. Coming on the right spectrum, that is the diffuse, we have the anti-topoisomerase 1. They have progressive disease, very short involvement, that is from the symptom of onset of Raynaud's to developing a progressive disease. Patients develop digital ulcers, ILD, myositis, arthritis, contractures, and also scleroderma renal crisis. The other antibody which is most important for scleroderma renal crisis is the anti-RNA polymerase 3. Now, these patients actually have more of SRC, GAVE, as well as malignancy, which is very important. The anti-Fib antibody also produces more of a diffuse spectrum. Now, anti-Fib is when we do the scleroderma profile, then we are able to locate the anti-Fib antibodies, and these subset of patients, which these antibodies are seen in 5 to 10% of these patients with diffuse clinical picture, they would have more of cardiac disease, pulmonary artery hypertension, ILD involvement, and GI disease. Now, in between these two, we have patients who have an overlapping picture like MCTD with U1 RNP positive, anti-KU having myositis, PAH, ILD, and some thrombocytopenia, anti-PMSCL positive, they have myositis, ILD, calcinosis, and the newer antibodies like the anti-RUB, which have myositis predominant. So, when we do lab tests for these patients, we should do an ANA immunofluorescence with reflex to ANA profile, because in ANA-IF, as we discussed, we'll be able to see speckled or a homogeneous pattern, and then the homogeneous we would not be able to differentiate it well with lupus, so we should do the ANA profiles. And better, if the patient is able to afford, we must do a scleroderma profile. So in the scleroderma profile, as you can see, normally when we do an ANA profile, we have the standard, the SCL70 and the, as you can see, the SCL70 and the centromeric antibodies. However, when we do a scleroderma profile, it almost costs around 5,000 rupees. And here you will be, if you have a patient with Raynaud's and other puffy hands and other pictures, it's better to do a scleroderma profile, because when we do scleroderma profile early in these patients, we'll be also be able to get the RNA polymerase 3, which is missing in the ENA. We'll be able to get anti-Fib antibodies and other scleroderma overlapping antibodies and scleroderma associated antibodies, which are only seen in the scleroderma immunoblot. So we should be doing that more often. Now, for those patients who are ANA and ENA negative, they could have cytoplasmic fluorescence, and these patients also could present with a diffuse skin disease. They could be, usually they are males with more of interstitial involvement, myositis, and arthritis with ILD. So, these antibodies are the newer antibodies like the anti-ELF2, RUB, and the anti-VICD2, which are not tested in our common laboratories. Apart from these antibodies, patients also have functional antibodies. Now, they have therapeutic importance because anti-endothelin 1, anti-fibrinolin 1, angiotensin type 2 receptors, matrix metalloproteinases, PDGFR, NAC2, CXCL4, anti-TGF, all are playing an important role in progressive skin fibrosis. Anti-muscarinic 3 antibodies, where in one of the patients, in the articles I read, pyridostigmine was tried and it improved GI dysmotility in patient at muscarinic 3 antibodies, anti-vinclin autoantibodies. So these are more of functional antibodies. So to identify a patient, we should see what is the age of presentation. Is it juvenile onset? Is it a usual age of onset or a late onset? So in a late onset, you're more careful with the malignancy. What are the autoantibodies positive in the immunofluorescence as well as in your scleroderma profile? What is the ethnicity? Caucasians would have more of limited, the African Americans would have more of fibrotic and diffuse disease. What is the extent of involvement? Their skin profile, the phenotype, whether it's a vasculopathic, fibrotic, inflammatory, or what is a progressive? Is it a very rapidly progressive skin disease or a rapidly progressive ILD? And at what stage the patient has presented to us, a pre-scleroderma, a undifferentiated, a very early, or late. So for every patient, no matter what stage they are, we have to do the ECG, the echo, the pulmonary function test, the DLCO, the chest CT, and also blood pressure monitoring, and especially for patients with the anti-RNA polymerase 3. Anti-RNA polymerase 3 age-appropriated cancer screening and SRC risk should always be monitored. These patients usually have diffuse, and even in patients who are ANA positive and ENA negative, all the organ screening should be done with the basic test, as we can see. Now, coming on to the malignancy risk. So, we should, patients with antibodies like the RNA polymerase 3, the anti-topoisomerase 1, have higher risk of breast and lung cancer. The antrocentromeric is actually protective for lung cancer, and they have more of GI cancers. Even the triple negative one, the incidence of cancer is around 7.7 to 14.9%, and after an absolute interval of 10 years, there could still be risk of breast cancer or melanoma. PMSEL antibodies have an undifferentiated relationship with cancer, and TH2 could be protective for cancer. So these antibodies could also tell us what malignancies we should be screening. Additionally, they also have a therapeutic importance. Like for tocilizumab in diffuse disease, it worked better in patients who are topoisomerase positive, and it was able to decrease the rate of lung function decline in the topoisomerase positive patients. Nintedanib in ILD, there was a greater preservation of lung function in the topoisomerase negative, but it was not statistically significant. And the riociguat in diffuse patients, there was no significant impact in reducing skin thickening. But on a subgroup analysis, they saw that it was able to reduce the skin thickening in a RNA polymerase patient positive rather than a topoisomerase positive. So our clinical approach is that scleroderma antibodies are important from the beginning. First, in diagnosing an early disease where patients would just have Raynaud's or nail-fold capilloscopy findings or puffy digits. Furthermore, they would help us how to screen patients doing esophageal manometry, chest, CT, basic blood workup. Then, functional antibodies could be important in developing new therapeutic interventions so that to reduce the skin fibrosis, lung fibrosis. Eventually, of course, in the diagnosis of established scleroderma, and also for monitoring their disease and prognosis. I would like to conclude by saying that although antibodies association is important, every patient is at risk for any of the scleroderma related organ disease. Therefore, we should screen all of them with HRCT, DLCO and PFT. Early detection of pulmonary artery hypertension is important, and those patients RNA polymerase 3 antibody we find positive, we should monitor their blood pressures, screen them for SRC as well as breast and lung carcinoma. Thank you so much.
Good afternoon, everyone. I am supposed to do some practice or tips on this. So, Sonal has already covered a lot of these things, and can you please change the slide? I think these scleroderma antibodies are still a evolving field, compared to other diseases like inflammatory myositis or ANCA vasculitis. So these antibodies may have multiple roles in future, right from diagnosis to prognostication of this condition. So it may have a role in early diagnosis of systemic sclerosis, especially in individuals who have what we call as VEDOS, early diagnosis of systemic sclerosis, who may have Raynaud's phenomena and then puffy hands. So in them, along with other factors like NFC changes, ANA positivity, our scleroderma specific antibodies may predict progression into systemic sclerosis, because 50% of these patients progress to systemic sclerosis, and combination of the ANA, scleroderma specific antibodies and NFC changes may help us in that. Other important thing will maybe that prognostication or risk stratification in ILD, PAH or SRC, wherein doing these antibodies may help us to identify people in whom we may have to do more frequent monitoring, and maybe in resource poor setting we may even use them as targeted use that the antibody positivity. We can do tests in people who have the antibody positivity versus negative. And more, I think the most important message in this will be the risk of malignancies, because scleroderma is associated with increased risk of malignancy. It's one of the most malignancies are one of the most common cause for non-scleroderma related mortality, and the risk is almost 40 to 70%. And the risk is most with anti-RNA polymerase antibody, which is almost 7 to 10 fold, and then other antibodies are also increased risk. And as Sonal said, a lot of these patients may require age-appropriate screening for malignancy. So as of now, we don't have any consensus or any guidelines for that, but may require. And these antibodies may have some therapeutic role in monitoring, though it is too early to say and the data is very less, but in future it may be relevant. So just to summarize, so these antibodies, like what we have in myositis or ANCA vasculitis, these antibodies may have a role. We may in future have a hybrid, classification criteria where the cutaneous involvement plus the antibodies may give us, more direction, use them as prognosticate markers, and then help us in management of this condition. Thank you.
So next I would like to call Dr. Kaushik Bhujani, the pregnancy outcome in systemic sclerosis real world data.
Hi, good evening everyone. Pleasant surprise to see that people are interested in scleroderma pregnancies. So that's nice. But more creditable is the fact that obviously the organizers have put in a lot of hard work. The two areas of research that I've been working on for the last 11 years are systemic sclerosis and recurrent pregnancy losses. And so what the organizers very smartly did was just give me scleroderma pregnancy. And let's go straight to the data. This is a meta-analysis published in 2020 comprising of 16 studies which combined 1,400 odd pregnancies versus 12.2 million healthy controls in terms of pregnancies. As far as the scleroderma patients were concerned, the duration of illness was more than 7 years, so it was a late disease, and almost half were the diffuse variety. And the fetal outcomes, the adverse fetal outcomes versus the healthy control population showed that the miscarriages were higher, the rates of IUGI were much higher, the preterm babies had an odds ratio of 2.4, and low birth weight was hitting the roof with an odds ratio of 3.8. And this is possibly the etiopathogenesis. So on the left-hand side, what you see is the histopathology of the placenta, the gross and the microscopic, and on the right-hand side, what you see are kidney biopsy pictures. And if you notice, you will find a little bit of similarity. So in the placenta, you'll end up seeing perivillous fibrin deposits, you'll end up seeing hyalinized decidual vessels with fibrinoid necrosis. Now compare that with the fact that you have a myositis proliferation along with endothelial wall edema causing the onion skin, which is very classical of scleroderma renal crisis. And if you look at the gross picture, even then you can see the fibroedematous thickening. So there is a similarity, and what is really happening at the placental level is what is possibly happening throughout the body in terms of systemic sclerosis. Maternal outcomes. Now these studies were very heterogeneous. Each of them had a separate primary outcome Some of them didn't have records because all of them were looking for something else. So somebody was only looking at the risk of abortions, somebody was only looking at low birth weight babies, somebody was looking at only maternal outcomes and so on. And nobody has correlated it with antibodies and so on that Sonal was talking about. And so it's very difficult to get numbers as to exactly what really happens to the mothers along with the adverse fetal outcomes. However, the take-home message here amongst the studies is more or less there's global stability of the disease in about 60 to 65% of mothers. 20% have roughly worsening and about 15 to 18% have improvement. What is very, very clear is the fact that you have a definitive improvement in a significant number of people in the vascular and the skin manifestations of scleroderma versus a definite worsening as far as the GIT is concerned. And that's not a wonder, isn't it, as far as GIT is concerned. So what about the fertility and conception? So all these people, when they have looked at whatever data has come out of these papers, what they've realized is that even though scleroderma, usually the onset is between 40, 45 and 50, nowadays you have later ages of marriages, later conceptions, you have infertility consults and infertility IVFs happening. And so you see scleroderma patients coming to you even after the age of 40 and they are willing to conceive or they are already pregnant, and so our exposure has increased. Now, there also might be a delay even if the scleroderma has come in earlier, and that's because of the fact that they can't really have increased sexual activity because of all the organ manifestations that they have, whether it's MSK, whether it's decreased lung capacity, whether it is decreased ovarian reserve because they've received cyclophosphamide, whether there's a psychological incidence and so on. And so, let's go to the maternal course because they've realized that if you account for all these confounders, the fertility rate is really not very different from the healthy controls. Now, what would you look at in the maternal courses? So about 5% of patients would have scleroderma renal crisis in early diffuse disease, obviously in line with what Sonal has just told you about the fact that RNA polymerase III, higher doses of glucocorticoids, which all of us know. And the scleroderma renal crisis usually happens in the second and the third trimester. This was actually documented by Virginia Steen, who's done the maximum amount of work, and she left the ball rolling in terms of studies of scleroderma pregnancies. And so there's one perspective, one retrospective, and so on. And what you need to remember is, all of you know what scleroderma renal crisis is, but how will you differentiate between preeclampsia and scleroderma renal crisis? And so if there's a daily rise in creatinine and a plasma renin level is elevated, then it's possibly scleroderma renal crisis versus a high uric acid, which would point towards a preeclampsia. And the fetal adverse effects of ACE inhibitors notwithstanding, whether you talk about the pulmonary hypoplasia or the renal atresia, just go ahead and treat, preferably with shorter acting ones like captopril and so on. Pulmonary arterial hypertension is a contraindication straight off as of now, and there are reasons for this. The maternal fetal fluid volume increases and the systemic vascular resistance decreases. So the cardiac output is much more, but the pulmonary vasculature is not going to allow that. So you will end up having right heart failures, PAH crises, malignant arrhythmias, and death. And the maternal mortality is unacceptably high. Must remember, endothelin receptor antagonists are teratogenic, and so they are contraindicated in pregnancy. And hence, avoid. Interstitial lung disease happens in more than 50% of the patients, and most of your drugs for ILD are contraindicated, except for azathioprine, which now the latest data shows that it may or may not be working, and if at all, you might use it for maintenance. So you could go ahead and try that. But fortunately for us, ILD usually doesn't seem to worsen during pregnancy. It's just that the work of breathing is increased, and that's why there's a problem in terms of hypoxia. So if post-vital capacity is less than 50%, avoid. I spoke about the GI issues worsening. That's a little wonder, isn't it? Because you get nausea, vomiting, decreased peristalsis even in pregnancy, and scleroderma itself has esophageal dysfunction, so that's all right. The Italian multi-center prospective study comprised of about 99 patients with 109 pregnancies studied between 2002 and 2011. And what they saw was that arthritis was more or less stable during pregnancy. And your only options anyway are hydroxychloroquine and prednisone with an SOS, non-selective NSAID. But what's important is our workup. We tend to forget the fact that the anti-Rho antibody can be significantly positive in scleroderma apart from the antiphospholipid syndrome. So we need to look at that and make sure that all our drugs are off 3 months earlier. And calcium channel blockers, and I will come to that slide on drugs, but essentially nifedipine is the only one which has actually been tested, not the amlodipine and so on. And periodic uterine and umbilical artery Doppler is mandatory along with the obstetric ultrasounds that we usually do, and aggressive management of hypertension, because you don't know which one is leading where. But this is where the rheumatologists need to come in. We do not seem to participate actively during the delivery phase, which is when we need to dictate and call the shots and tell the obstetrician that our patient will end up getting digital gangrene, will end up getting an excessive cardiac failure if she strains so much, and you can't allow vasospasm happening there, in which case you need to have thermal blankets, preheated IV solutions, avoid the general anesthesia, use epidural and use lesser doses, because otherwise they have a prolonged motor block, and avoid ergotamine and oxytocin in cases who have even mild PAH. Postpartum worsening can occur, usually occurs in scleroderma less than 4 years, mainly skin, Raynaud's, digital ulcers and arthritis, but the PAH can worsen. And mind you, postpartum monitoring is something that we don't seem to do because of various reasons, right from the mother not following up because the child is very young and so on. But a scleroderma renal crisis can happen up to 1 year after pregnancy. So reinstitute your vasodilators quickly. This is the list of drugs. All of you all know all of this, so I'm not going to go through this and waste your time. However, I've already mentioned the fact that amlodipine, the studies are limited, so nifedipine is required. Now that comes with your caveat about the fact that you will worsen the esophageal dysfunction, and so you will have an increased incidence of GERD. But you don't seem to have a choice here. And of course the fact that I spoke about the endothelin receptor antagonists being teratogenic and hence have to be avoided in case your patient insists, does not listen to you, wants to go ahead with pregnancy. So I had one such case where the woman said, I don't care if I die, but I'm getting pregnant. And she did. And I had the hell of my time for the next 6 months, from the 3rd month to the 9th month. And by the time we delivered her, her pulmonary artery pressure was 90. It's a wonder that she's alive and she's still fine, because this matter is about 10 years old now. But the fact is that sildenafil can be used, iloprost can be used, epoprostenol can be used in case your pulmonary artery pressures start rising. So now data from Asia before I close. So this is a study from Iran, and as you can see that this is 2020 data, where they looked at 229 pregnancies before the onset of scleroderma, and they looked at 49 pregnancies after the diagnosis, and they found that even after diagnosis, 2/3 of the pregnancy outcomes were successful, about 67%. However, the number was much better if you had the antibody positive but the disease had not come in. And spontaneous abortions were higher, as expected in the Western cohort and the meta-analysis that I showed. Preterm delivery was also much higher. So we are no different as far as scleroderma pregnancies are concerned. This is from India, an SGPGI study, which was a retrospective telephone call based interview, and rest of the data was asked for by WhatsApp, the missing data. Average age was 31, so relatively younger age of 75 women, 127 conceptions but before and 15 thereafter. And here the pregnancy outcome was, the number was very small, but more or less coinciding with what's happening. So it was 60% success rate and 20%, in fact 33% failure rate. The preterm rate was also higher, but as I said, the numbers are very small. I just wanted to show it because we are making an attempt to collate our data with the world results, and which is why this study needs to be credited. And so Compared to the Italian cohort, the Indians had higher abortion rate, the IMPRESS study that I spoke about, the Italian multi-center study, and the higher LSCS rate. But I don't know whether the LSCS rate was higher because the obstetricians were worried, and that could be a confounding factor that she has scleroderma, so I don't know how she will heal or how she will behave if I tried a normal delivery. And compared to lupus also, our LSCS rate was much higher, as was the preterm deliveries. Thank you very much.
Thank you, sir. So for the next talk, I would like to invite Dr. Ramya J from Bangalore on updates on systemic sclerosis and CTD-associated PAH, predictors of survival.
Good evening, everybody. Today my topic will be the discussion on predictors of survival in scleroderma and CTD associated PH. As you well know that along with interstitial lung disease, pulmonary arterial hypertension is a major cause of mortality and morbidity in scleroderma. And pulmonary hypertension in particular is associated with 30% risk of early mortality in scleroderma. So I am sure that our audience is aware of the modification in the definition of pulmonary arterial hypertension. It has been got down to mean arterial pressure of greater than 20. It was earlier 25. Along with the previous part of the definition remains with elevated pulmonary vascular resistance and normal left heart pressure, that is end diastolic pressure of less than 15. So you should understand that most of the data which comes from India, etc., is mostly echocardiographic based diagnosis of PH in scleroderma. So strictly by definition, we can't actually call our patients as scleroderma pulmonary arterial hypertension because it has to satisfy this particular RHC definition of pulmonary arterial hypertension, because it is well known that at least 15% of scleroderma associated PH is due to left heart disease. There are other causes of scleroderma associated PH that like pulmonary veno-occlusive disease and interstitial lung disease related and CTEP, etc. So unless we do a RHC and we classify it correctly, most of our cohort we can't really classify them as pulmonary artery hypertension. However, this definition henceforth will be related to data related to scleroderma PH. So the upper limit has been reduced because the normal population upper limit is around 20, and therefore the definition as per the RHC has been got down to 20. And there is enough data now to suggest that those who have this borderline 21 to 24 tend to progress, at least 30% of them. Once they progress over a duration of 3 to 5 years, their prognosis is similar to those who have greater than 24 at baseline. So this is just a broad overview. It is not a comprehensive inclusion of the registries on PH which is available. So this includes both the CTD related, which is mainly scleroderma PH is well studied of our diseases, as well as idiopathic PH and other causes of the type 1 pulmonary hypertension. You can see that a lot of registries are doing good work from Europe, and there are registries from US and Australia. These are the main registries which have come up with these survival data. So I will initially be dealing with what is the survival data which is latest in scleroderma PH and the CTD PH, and subsequently I'll be talking about what is the most important feature which is determining the mortality and morbidity in pulmonary arterial hypertension associated with scleroderma. Subsequently, I'll be discussing about the screening strategies. So this is the latest data which is available related to morbidity and mortality events. This is a systematic review and meta-analysis which was published in 21. So from the trial data, it is obvious that CTD-PH patients are having somewhat similar outcome in terms of morbidity and mortality even during the trial period, which is comparable to overall PH population. Although the extent of 6-minute walk improvement is somewhat better in changes are all mostly expert opinion based and arbitrary. It's not backed by strong evidence, but it is fairly simple and it is easy to use. And most of the European registries are using a modification of the same in prognosticating their cohorts. So presence or absence of clinical signs of right heart failure, if there is a progressive symptoms or stable symptoms, presence or absence of syncope, WHO functional class, and few features which I have already discussed, the 6-minute walk distance, cardiopulmonary exercise testing, anti-probenity, these are the things which are coming in addition to the hemodynamic parameters which are picked up from the RHC. So the REVEAL registry data is somewhat more evidence-based. So they have based it, I think, on their whatever prognostic factors they found on their multivariate analysis. It is somewhat more complicated, but there is a calculator which is available. They have also included something like demographics, comorbidity, and the vital signs and all-cause hospitalization in the previous 6 months. These are the additional things which they have put into their calculator. So from data we know that REVEAL registry data, the REVEAL prognostic score is doing somewhat better than the risk assessment which is based on this ESC-ARS guideline. So this is the French PH cohort who do quite a lot of good work in scleroderma PH, and they have used a modification of the ESC-ARS risk assessment guidelines. So they have only taken into consideration these 4 things: the functional class, whether it is 1 or 2, 6-minute walk distance which is more than greater than 440, and right atrial pressure which is low, and cardiac index. And they have shown that those who are having at least 3 of these features, so they seem to have a low risk, and they have a significant reduction in all-cause mortality and hospitalization due to scleroderma. And they are also able to, based on this number of criteria which the individual patient is satisfying, it is having a differential mortality risk which is shown in the figure. So I'll come back to this progression in a repeat RHC when I'll be discussing about screening, etc. So from what I have reviewed, I have come to the conclusion that from the clinical point of view, WHO functional class remains the most important factor which is determining the survival. So from REVEAL registry is one of the largest data which is available. You can see that depending on the functional class, so the class 3 and class 4 seems to have the worser prognosis over years. And the other important thing is REVEAL registry also has a significant number of patients who have undergone repeat RHC within an year. So on scleroderma specific, the PH specific therapy, if there is an improvement in their functional class, they also tend to do better. So those who remain without improvement on therapy, they are the ones who do the worst. So coming to the screening part, so after the review, I realized that detecting patients early is the only thing which has actually altered survival in a significant proportion of patients over these last, I think, 4 or 5 decades in which they are treating PH. So how do we pick up patients? So scleroderma and CTDs this is one unique situation where we have patients who have a prevalence of scleroderma PH in as high as 8 to 12%. And this is one unique population where we can screen them, that is even before the onset of symptoms, diagnose it and start PH specific therapy and alter their prognosis in a very largely significant way. Otherwise, idiopathic PH and other causes of class 1 PH are very rare in the general population, and it is impractical to screen the entire population for the occurrence of PH. So already stressed upon. So the cumulative incidence of PH in scleroderma as patients tend to live longer is coming up to 19% in some of the series. So it is a disease with a high prevalence of PH, and since it is associated with mortality, it is utmost important that we screen for every patient along whatever the guidelines are suggesting, even before the onset of symptoms. And one would think that the screening strategy has it really changed the prognosis in scleroderma, because the meta-analysis data doesn't seem to have any impressive change as compared to previous decades. So from that point of view, I would like to highlight one or two cohort studies. So this is the initial cohort study from the French group. So you can see that the patients who had been detected by routine practice as compared to the patients who have been actively screened for it, whatever was available at that point of time. So their hemodynamic parameters by RHC was comparatively better, and most of the more patients have presented in class 2 and class 1 in that subset, and they have had a better prognosis. So similar data was also seen from the Australian scleroderma cohort. So those who have been screened, more of them are in class 1, class 2, and they are having better hemodynamic parameters as well as prognosis. And this is the latest data from Pharos registry, which also shows the same thing. The other important thing you have to note is in this Pharos registry, the scleroderma specific mortality during the early years was, that was the main contributing factor, but there is mortality related to other causes as well in this cohort. So in summary, the screen population were reported to have better risk stratification parameters, and this has also been proven by a recent meta-analysis on screening. So in the absence of a screening strategy, majority of scleroderma patients, and including idiopathic PH patients also, they are presenting when they have functional class 3 and 4. Therefore, it is of utmost importance. So I would like to highlight these two epidemiological concepts with respect to screening. We may feel that we are doing a better job just by screening, but we may be picking up the patient early on time, and there may be a lead time bias. So we are picking them up early, and we may falsely show that they are living for longer. But as we have a data for longer duration, 8-year mortality, which is also better than the pre-existing cohort, I think it shouldn't matter. The other thing is there may be more deaths in scleroderma PH which are picked up early, which is unrelated to PH. So falsely low mortality also may be represented. So screening recommendations, since it's not a part of my topic per se, I will be going through fast. This is the latest one. So they have included scleroderma spectrum, which means that they have prominent scleroderma features in addition to those who are diffuse or limited scleroderma, which includes NFC and SSC specific autoantibodies and uncorrected DLCO of less than 80%. So the appropriate screening tool which is adopted by ESC ERS is these four: detect, and the recommendation for echocardiography, FVC DLCO ratio of greater than 1.6, greater than 2-fold upper limit of normal of NT-proBNP. So I will not be going through these slides. So irrespective of this, so we have, other than TRV, there are other echocardiographic signs. It is available in the document, please go through. So which are also suggestive of suspicion of PH, and you should refer them for right heart cath. And I would like to highlight only two more points, that is a significant proportion, around 20% of patients who are in functional class 1 and 2 also worsen over the initial follow-up period. So repeat RHC is also of relevance in terms of prognosticating, and as previously discussed, those who have borderline also around 30% of them progress. So, and they tend to have a worse prognosis. And from our part of the world, especially India and China, appear to have SLE-PH in greater proportion as compared to scleroderma. If you look at overall CTD-PH, we should be aware of it. And there are some registry data from China which I will not be discussing, and this is some unpublished data from our group. We have some amount of interest in immunosuppression in the CTD-PH, especially SLE and Sjogren's. We have a good prognosis in the background of some vasodilator therapy. So in conclusion, scleroderma PH is a disease which is associated with early mortality, and screening is improving mortality. Thank you.
So any question and answer? It's open for question and answer. So we would like to conclude this session. So the next session is in Brigadier Menon Hall, the great debate of Iracon.